Jungle. Audio Jungle. Audio Jungle. Audio Jungle. Audio Jungle.
Welcome everybody back here in the studio. Stay tuned because this broadcast ain't over. What's going to happen in the next 20-25 minutes is that while the session in the room is being ended, we are pulling our speakers from stage, running them over here to the backstage studio, where we'll try to even deeper and further get the real practical takeaways from this session. So we already see quite some questions coming in from you in the comments on Facebook. If you just joined us, that's the way it works. We're live, so you can type in your questions and we will try to answer them either by our speakers or by our two experts here with me in the studio. And I'm very proud and honored to be joined by Oscar Gonzalez from Madrid here in Spain and Frank Schwarz from Düsseldorf in Germany. Gentlemen, we see quite a lot of people are watching, a lot of people also tuning in later. So if we try to summarize what we've just heard on stage, how would you grasp the message of this session?
Okay, I think we have just saw an excellent review of three great clinicians and also two great moderators with a lot of experience and giving us ideas about how to approach this type of case. I will first, I would like to highlight the fact that they have been very honest. They have shown difficult cases to us, cases that any of us will be, crazy about it when they show up in your office. So they are very difficult situations to be solved. And not only that, the way the session has been structured, it was presenting three different scenarios: single, partial, and full rehabilitations. And three of the situations that they are completely different. Even the way we approach them, even the way that we can deliver the message to the patients to say, listen, we can solve that, or to be honest, we cannot.
Yeah.
And still, I want I'm looking forward them to be here because we have still some questions. Still has been very amazing for us. The move to the machine implant. And that we were going to ask these two guys with so much experience, two big clinicians. Wow, the companies goes through this way, and what's going on that you're moving to something different, and so still a lot of questions, and we're looking forward to have them here.
Well, they're hopefully on their way, and in the meantime, let me do a quick shout out to all the active commenters. I mean, we just see Abdelkader Banani, regards from Morocco. We see Cassius Farina from Brazil. Good morning to you guys, and I guess good evening to all our friends in the Far East. Glad you're still with us. Stay tuned because the speakers are soon coming. Frank, if you look back at this session, what is your first reflection?
So the first reflection is quite clear. So implant dentistry is not forgiving. It means when you run into trouble, it even becomes more difficult. So this is the basic message that we should keep in mind. So to start from the very early beginning at a stage where we can overcome problems. So
exactly. So, and I guess it's all about, we just heard it in the final discussion about the threshold, both of taking a problematic implant out or in, but I guess also the threshold of when to keep things in your own practice and when to refer to a more advanced professional, right? Well, any indicators to determine whether or not you should try to fix things yourself?
Wow, that's a very complex question to answer. No, I think each one should know. As I said at the beginning, I think diagnosis is key. So I think you have to analyze the case and then to make sure that the factors that are involved in the case, we are able to solve them. And if so, if you have the skills, or even if you want to go into this type of treatment, or you prefer not to. And that's something that each professional knows.
Is a personal
Absolutely.
determination.
Absolutely.
Yeah, I think this is really speedy. Let's move over.
Yes,
If you guys
good.
move to this
For
side
sure.
of the table, we're going to welcome our three speakers here live in the studio. Gentlemen, congratulations on this
Very
wonderful
nice.
session. We've really enjoyed it here live from the studio, and I think our online audience is quite happy with it as well. And they've been sending in questions. But before I'll take to them, I'll let my experts take the honor of taking the first questions to you.
Well, so
Oscar, start.
okay. So, as I say, we have been discussing, and we first of all, congratulations. It has been amazing, not only for the clear message, but also for the honesty, to be in front of all these fellows and show these difficult cases. Not everyone is allowed to do that, and so thank you very much. But still, when we have seen the question from the people and discussing with Frank before, what is a hopeless implant?
What is?
Yeah, the session title is dealing with hopeless implant. When is an implant hopeless?
I know you were talking about malposition implants. I was talking about infection. There is something else, or basically this is the two big factors that you will consider not like an hopeless implant.
It's right. Nobody asked us about the title of the session. Give a lecture on this topic.
Yeah.
No excuses.
It's a good no excuse. It is a good question. An implant that you can't keep in the patient's mouth because of the real critical outcome of the soft and hard tissue. This is a hopeless implant.
That's what we call when the decision is made to take it out and start doing something new.
Yeah. Also, I think that an hopeless implant is an implant that in your treatment planning, you will do a better job if you remove it instead of trying to save it.
Okay.
That's
So-
a beautiful answer.
That's the real thing. If you decide that you will do a better job, you just take it off.
Yeah. It's going back to the greenfield situation, so to speak.
Yeah. I think if we're looking for a definition, maybe a hopeless implant is that one that can accomplish a restorative treatment, can accomplish a health for the patient, and can accomplish the aesthetic outcome that the patient normally looks for. Mm-hmm. Then it's a hopeless implant.
And we have to start over.
We start over.
Yeah.
Beautiful answer. Thank you very much.
Yeah. So maybe we can just stick with.
I stay with the microphone. Okay.
In your presentation, you have briefly commented on a lack of consensus regarding the disease definition, which is not really reflecting what I'm aware of. So we have a quite good consensus on the disease definition. Mm-hmm. We have a lack of consensus on a case definition, but we have a proper consensus on the etiology. So I wouldn't question the etiology in the absence of data pointing to a different etiological. So factor rather than plaque. So this was a little bit
No,
Curious for
the
me.
comment is that there is, I think, it's not my thinking, it's on the literature. There have been a lot of workshops with some kind of definitions regarding the clinical aspects.
for the case definitions.
The case definitions. But as you know, very recently, we have heard and we have read about disbalanced foreign body reaction, which is not the same as an inflammatory and infective disease.
Yeah.
That's why I pointed out it's not a consensus, because are two etiologies completely different. And when it goes to the definition, this is what with a research that has been done and has been published in 2016, that the conclusion was not really a consensus in the definition there. Yeah, that's because the literature.
Yeah.
I know. I have a perfect idea what is periimplantitis. I can
know.
tell you.
I know. But this is not the topic here, but just to being precise, since many people are a little bit confused coming from the web response. So we have in preparation of the upcoming EFP AAP World Workshop, there is a clear consensus on the etiology, and all the other things are hypotheses that needs to be proven, but not by the community that has provided the proof that plaque is the etiological factor.
I personally think that there is a need for clarification of it, because it's a problem that we are facing more and more and more, and we need to have a clarifying definition, etiology, because we need to treat patients.
Yeah. That's true. But this is well defined, so.
Okay.
Shall we go to a question of our online audience? Because our online audience is really dying to bring this into the practice next Monday, right? So what are we going to do different? I take a first question from Sarah Renfield, who is referring to the theme of predictability, which is the key metric here, of course, when we're doing this. And she's asking, how predictable are implants which have been placed in a location where a previous implant has failed?
Excellent.
Other question: how predictable is an implant in a place where a tooth failed?
Yeah. Okay. So is it?
So if you do not have the history of a failing tooth, most of the time it's periodontitis. Then you do not have you can be sure that an implant will be 100% successful in this mouth cavity, and that's what we see in an everyday situation. Primarily, we were happy because we did not know nothing. We were placing implants. Now we have to deal with the consequences. And when you go through the situation in our country, we have the mouse study all over Germany, and it says the most teeth are lost because of periodontitis or chronic periodontitis. So then we have to think about why should an implant not get the same disease?
Yeah.
We have not the answer yet.
We don't have the answer yet, and basically,
but we have to
there's
deal.
No specific difference whether the implant was failing or the tooth was failing. Are you agreeing, Massimo?
Yeah, I totally agree with Karl, but I would like to give an answer to the colleague. It depends on the reason why that implant failed, because if you remove an implant that failed because of a malposition and you place a new implant in a good position, you have a lot of chances.
Solve the source, yeah.
If you remove an implant due to the infection and you remove the implant and solve the infection and place a new one, you have good chances to have a successful implant. Exactly. If you place an implant in the same wrong position and you don't treat the infection, you don't have any chance.
So again, we're back to your point about it's all about the diagnosis being right. Yes?
One comment on removing implants. Patients, they don't want us to remove implants. Even if an implant is only 1/10 of a millimeter in the bone, for the patient, it's stable. Exactly. The only pressure the patient has is pain. Only when they have pain, they are ready that you can take the implant out. On the other hand, we have to deal with the patient and give them information why an implant that is a failing implant should be removed on the earliest time possible.
Yeah, and I think that's aligned with what we talked about before the session, that it's such a complex matter of biological, functional, aesthetic, but also these interpersonal dimensions in the field. If you allow me, I'll take another question from Jamil Awad Shibli. It's kind of a long question, so bear with me. We do not have any evidence that roughness surface is more susceptible than smooth surface to peri-implant diseases, except HA and TPS surfaces. Could the speakers please clarify this issue? There is a difference between marginal bone loss and biological width. Thanks, he says. I'm just reading out the question, but thanks for your question. So the matter of the different surfaces and its influence.
I gave the answer. I can see in my cases in implants where we have a small or a wider polished collar. If you place the polished collar underneath the bone level, you will have a craterization, and the crater always stops at the smooth, rough border, because it's not an infection that causes the problem, that bone loss. So you have to place the rough, the polished collar above the crest, and the rough surface always in the bone level. And if there is no soft tissue infection, you will have a stable bone level over many years. The moment you see mucositis, and from the mucositis you have a penetration of the bacteria to the bone level, then you have a peri-implantitis, and then we deal with the issue that was very nicely presented yesterday by my friend Frank. Okay?
Clear? Anything to add?
I have.
Please do.
If you look for the evidence, many years ago when we were using, no, I wasn't, but when people was using TPS implant surfaces, there were a lot of preimplantitis, but at that time there was no evidence that TPS surface was creating more perimplantitis than machine surfaces. So people will continue to use because they didn't know and there was no evidence. Here we are in a similar situation. We are understanding now, not now, but it's just few years that we understood that the rough surfaces are more susceptible to infection than machine surfaces.
Yeah, but
that's
once
why
they are exposed. That's
Exactly.
the addition.
Exactly.
But this needs to be
Exactly.
clarified.
Once they get exposed
Yeah.
over the bone level. So when we have a rough surface that is completely under the bone or in the bone, doesn't create any problem. But once gets exposed, that's the plaque accumulation is faster and different. So that's the situation.
I think.
Joan, yeah?
I just want to add that we are Massimo and I. We arrived to the same conclusion in a completely. Milano from Barcelona is quite far.
Yeah.
But we arrived to the same. And maybe it's not evidence on the literature, but on the clinical, we have seen this difference. We have, and our patient has suffered from this. And we arrived to the same conclusion. Even when you proposed, you gave yesterday a very nice lecture about treatment. And most of the treatments, you convert the rough surface to a polished surface. Why don't install directly a machine surface?
Yes.
Instead of waiting for a peri-implantitis. And I totally agree. If the rough surface is not exposed to the oral cavity, no problem.
Good.
The problem arises when it's exposed.
So maybe to go back to this answer,
Yeah.
there is indeed clear evidence that once they are exposed, the progression is much faster. So basically, I like the idea, to have a machine surface subregressally.
Yeah.
I think we don't have a clear evidence yet because we are just in the beginning. But I'm sure in my heart that we will have soon.
We will have soon.
Yeah.
Thank you very much for sticking with us through the end. And if you know anybody who might find it interesting to learn more about failing implants and what to do and where the thresholds are, make sure you tag them in the comments or share this video on your timeline on Facebook so everybody in the world can benefit from these latest insights.